Good morning. It's a pleasure to be participating in the Pediatric Diabetes Update-2020 conference. I'm going to be speaking on the initiation of insulin pump therapy and very much from a practical approach. Insulin pumps are widely used and considered core therapy across the world, but we do know that they're not suitable for everyone and nor accessible to everyone. The Type 1 Diabetes Exchange Registry showed that there was no indication that HbA1c levels have improved in the USA despite an increased use of pumps. However, improved quality of life, reduced hypoglycemia, and a reduction in complications has been shown. Any well-skilled diabetes team is capable of running an insulin pump program. So what is an insulin pump? It's an electronic medical device that delivers insulin based on programming, essentially. So we use a range of pumps at our service. There are many pumps, of course, across the world. We tend to lean toward Medtronic or tandem T-Slim pumps. And the point of difference across pumps generally is some are battery operated, some are charged via electricity, some are piston driven in terms of driving the reservoir. Others have a pouch cartridge, such as the tandem pump, which is pressure driven. Probably the biggest point of difference at the moment would be whether the pump is software updatable or upgradable, because pumps are changing so rapidly in terms of technology, and there's nothing more disappointing than getting a new pump which has a 4-year warranty, so it can't be changed until 4 years, and then a couple of months later a better feature comes out. So that's certainly the tandem T-Slim has an edge for that, because it is updatable or upgradable, but Medtronic certainly are addressing that as well for the future. Medtronic pumps operate off button pushing, whereas the T-Slim has a nice touch screen, which many people find attractive, similar to a mobile phone. Both are compatible with continuous glucose monitoring, and this affords benefits such as predictive low glucose suspend, so the basal rate will stop to avert hypoglycemia, or even better, for example, in the 670G, automated basal delivery, which I'm sure you've heard about in other talks during this conference. And certainly the T-Slim is able to do both of these things as well. So what are the advantages of pumps? Now, I'm not talking about the clinical advantages, I'm talking about the practical advantages. Flexible insulin delivery is by no doubt probably the most important thing. So insulin, if you're on multiple daily injections, you get 4 chances a day to make some adjustments. Whereas on a pump, you can adjust your insulin delivery more in real time and on cue when needed. So temporary rates can be applied to a pump. So for example, for exercise, a temporary basal rate can be set so that the patient's receiving less insulin through the basal menu, which means that they're less likely to become hypoglycemic. Or alternatively, on sick days, they can run their temporary basal rate higher to account for sick day hypoglycemia. Extended boluses can be given, so prior to a meal, instead of giving all the insulin up front, it can be given over a nominated time period. We find this very useful in high-fat, high-carbohydrate meals and can be well educated by the dietitian. So it affords a lot of flexibility around lifestyle. The no injections is a huge bonus for children, particularly. Children are generally in the care of other adults, such as teachers, grandparents, family, and friends. I'm not sure what your experience is, but I certainly find most people find it a lot more acceptable to observe or assist the child to deliver insulin through a pump by button pushing than they do by putting the needle on the end of a pen and giving a child an injection. Teachers don't like to do that. They're worried they're going to make a mistake. They fear hurting the child, and pumps seem to be far more tolerated and acceptable. And then the other advantage by far is the recording of data. So how many of you have patients that come to see you in the clinic and you ask them how much insulin they've given themselves and what their blood glucose levels have been like. They've forgotten their blood glucose meter at home. They haven't written it in a book, which is boring to do, and they give you a very vague and anecdotal account of their diabetes management over the last 2 to 3 months. And it's really difficult to help them achieve their goals with very little information on hand. A pump, on the other hand, everything's recorded. So, for example, below, you can see what this person's sensor glucose has been for 24 hours. You can see when they entered a glucose value into the pump, how much carbohydrate they bolused for, and what insulin was delivered. I can also, if I look at this tracing, note that there's been a rise in blood glucose between 9 a.m. and 12 p.m. So I'm suspecting they might have forgotten to enter their breakfast and bolus. And of course, this opens up the opportunity to have that conversation because you've got the information on hand. But there are challenges to pumps, of course. There is a cost involved. They're very expensive and not accessible to all. Carbohydrate counting accuracy is very important, and we're reliant on our dietitians to educate patients accordingly. Some math skills are involved. You need to be able to add. 24-hour aware is very important to emphasize to patients when they're choosing to go on insulin pumps. I find that this can be a barrier for patients to decide to go onto a pump, but I don't find it's a barrier once they've started the pump. There's so many more benefits that override it, and so you don't often have patients come back and return the pump because they don't like wearing it. They do get used to it. Of course, we do get set and mechanical failures. We're operating a machine, they break, and sets fail as well at the time of insertion, or they can dislodge during the 3-day use that we advise. Just like happened with this child below, you can see it happened the other day. Everything seemed to be going okay, and then by 3 p.m. blood glucose levels were markedly elevated and remained so until the next morning, and clearly that was a set failure, and we need to reinforce rules around how this gets managed and prompt action taken. So what do we need to start a pump? Well, we need the pump, of course, but also an infusion or giving set, and I'll talk a little bit more about them, but that's the part that connects the pump to the patient's body. A reservoir, which we fill with insulin and insert into the pump, and the insulin that we use for a pump is short-acting insulin only. And we do need to educate patients around why this is. Once they understand how a pump works, they realize they no longer need long-acting insulin. But we always ask that they keep at least 1 pen in the fridge available on hand in case something goes wrong with the pump and they need to go back to multiple daily injections. So to help explain how the pump works, we explain that the insulin is delivered via 2 menus. The basal menu is where the insulin is delivered constantly at a nominated rate, and this happens automatically without having to be adjusted day to day, and it really is equivalent to what they would be getting through their long-acting dose of insulin. The bolus menu, however, is driven by the patient. It is obviously set up with some predetermined bits of information to help it do its calculation, and then boluses are actually driven by the patient's button pushing. So the information that needs to go to set up the bolus menu are the carb ratios, the insulin sensitivity factor, the blood glucose target, and the active insulin time, and I'll explain this a little bit more. So how do we work out a basal insulin rate? Well, what we need to do is first determine what the patient's total daily dose of insulin is on multiple daily injections. That is the sum of their long-acting and all their short-acting insulin injections for a 24-hour period. We might choose to reduce this by 20 to 30% to do our pump calculations, because typically people are a little bit more insulin sensitive when they start pumps. The insulin delivery is more precise. However, if their HbA1c is elevated, we may choose not to reduce their total daily dose by 20 to 30%. So once we've decided what our pump total daily dose is, we need to work out what 40% of that is, because in our practice, we generally will put 40% of their total daily dose through the basal menu. So we take that total basal amount and we divide it by 24 hours to work out how many units per hour they're going to get. So these are just examples below. Everybody's different, of course, but a pre-adolescent child will probably have 5 basal rates programmed. Now again, if you look at other centers across the world, some people put 24 basal rates into a pump. We tend to choose around 5 time slots. which generally match more their level of activity and likelihood of hypoglycemia, such as overnight. We run the basal rate a little bit lower, a little bit higher earlier in the morning, down again during the day because of activity, maybe a little bit more up in the evening where there's less activity, and then slow down again before bed. With adolescents, the point of difference you'll note is that their basal rate increases early hours of the morning to counteract those hormones that patients, adolescent patients have, which cause higher blood glucose levels early hours of the morning and on waking. But typically that's what our basal rates might look like. And again, you will see variability across centers. How do we do bolus calculations? Well, first of all, we have to work out what the insulin sensitivity factor is. We use the 1800 rule for that. So the number 1800 divided by 40 gives us 45. So 1 unit drops the blood glucose by 45 milligrams per deciliter. To work out the insulin to carb ratio, we use the number 450 and divide that by 40, the total daily dose. And we get the number 11. So 1 unit covers 11 grams of carbohydrate. Now you'll notice that in blue, I've highlighted the rules we use at our center. Why do we use these rules? It's just a little bit of maths. We would have audited our patient population and found that most of our settings lean towards this anyway. And so we just decided to use these rules from the get-go. But of course, the 1800 and 500 rule are very common. But some pediatric centers might skew them slightly like we do. Active insulin time in our centers generally set as 3 hours. We figure the action time of NovaRapid is around 3 to 4 hours. So we program our pumps with an action time of 3 hours, but it can be programmed for anywhere from 1 hour to 6 hours in a pump. And our blood glucose target is 90 milligrams per deciliter or 5 millimoles. Of course, once all these calculations are worked out, the endocrinologist checks them and signs the order off before we set these in the pump. So just to make it a little bit more clearer, 12-year-old girl on a total daily dose of 50 units. So we would take the 50 units and work out what 40% of that is, which is 20. This then gets divided by 24 hours and gives us a rate of approximately 0.8 to 0.85 units per hour. The insulin sensitivity factor works out at 36 milligrams per deciliter, and the carb ratio, 1 unit covers 9 grams, works out on the rules. And the target we put in the pump is 90 milligrams per deciliter. So, for example, if this patient's blood glucose is above target, sitting at 162 milligrams per deciliter, they're going to need a 2-unit correction to get them back down to 90. If they're eating 30 grams of carbohydrate, they're going to need 3.3 units to cover that. So their total dose of bolus dose will be calculated at 5.3 units. So I set up this pump to reflect that, and that's exactly how it calculated it out as well. Now, I will say one thing. You notice that there is active insulin adjustment on the screen. Of course, if this patient had already corrected their blood glucose within 3 hours, the pump is less likely to offer a full correction. It will reduce the dose accordingly based on the action time of insulin. So if it happened only half an hour ago, it would unlikely even offer would offer 2 units at all. The patient would probably only be offered 3.3 units to cover food. However, if the correction had taken place more than 4 hours ago, it's likely to offer the full correction. The pump does this. It's a safety feature set in the pump, and it's important because it avoids the patient overdosing on corrective insulin. So when we start our pumps, how do we go about this? Well, we like to start early in the day. There's a lot of information that has to be covered. And we also want the opportunity to supervise morning tea and lunchtime in real time on the pump. We start earlier in the week as well because we want the opportunity to bring them back and follow them up before the weekend. And also, if you started on a Friday and something went wrong on the weekend, there's not enough staff to help support the patient. We normally reduce their usual long-acting insulin by 60% the night before starting the pump, or if they're on a morning dose, we withhold the long-acting insulin. That's, of course, very important because when the pump is set up, the basal menu is going to take over and they're going to start getting basal delivery, and you don't want an overlapping of long-acting insulin and basal insulin. We ask them to use their usual short acting for breakfast and then present for education. And we help them set up their pump. The date and time is the first thing that gets entered into the pump. It's extremely important. You are able to set different carb ratios, insulin sensitivity factors, and basal rates at different times of the day, of course. Therefore, the time is very important on the pump. It drives the menus. So that's an important thing to mention to patients when they're considering traveling. And then we get the patient to set up their own bolus and basal menus. It's very important that the patient or the parent is able to do this, because when pumps break, they need to be able to set their own pump up, ideally at home when it gets replaced, or alternatively, when we want to do a rate adjustment, they don't necessarily have to come to hospital for that. We can ask them to do it remotely over the phone or via email. Key points for education are how to set the pump up, which I've mentioned, how to change the reservoir and set, and we always bring the patient back on 2 to 3 days after pump start so that we can supervise that set ourselves. Disconnecting and connecting from the pump. We ask that patients only disconnect and connect at the site of the cannula on the body, never by removing the reservoir from the pump. That's very dangerous. And also we limit the time of disconnection to a maximum of 2 hours a day, but preferably really only for the 20-minute shower. We teach the patient how to bolus for food and do corrections through the pump. We teach them how to set up a temporary basal rate for exercise and sick days, so they are able to reduce their basal rate to 80 or 70 or 50% for exercise to avoid hypoglycemia. And they're also able to increase their basal rate to 120 up to 200% on sick days when hypoglycemia is prevalent. We teach them around the action they need to take for ketones, because obviously I always explain to patients that where is all the insulin sitting at the moment? Most of it's in the reservoir of the pump, and it's being infused in small amounts into your body. That's different to being on multiple daily injections. If you've given yourself a Lantus injection, you're pretty much covered for 24 hours because the insulin's in your body and working slowly. You can't take it out. But on a pump, if the pump disconnects or the cannula dislodges, then the person becomes insulin deficient far more rapidly and develops ketones. We also discuss disconnection doses because pumps break and fail, and they need to be able to work out how to go back onto injections and how much insulin to use. And of course, we tell them who to call. Of course, it's us, but pump companies also offer very good tech backup. So what are our expectations of a patient on a pump? Well, we want them to enter blood glucose or sensor glucose values into their pump regularly. So at least 6 to 8 times a day would be the ideal. That doesn't, of course, always happen, but that's what we aim for. Bolus for all carbohydrates, so that means any main meal or snack that comprises carbohydrates needs to be entered into the pump, and insulin needs to be delivered for that. We ask them to correct their blood glucose or sensor glucose value when it is above target in between the times when they're bolusing as needed. Pumps afford us the ability to correct before bed and to correct overnight. That's not something we would typically encourage on multiple daily injections. We encourage them to use temporary basal rates for exercise and sick days, to do a set change every 3 days, and we want adult supervision. It's really important to note children are very clever with machines. They know how to push buttons and get things working, but they don't have the maturity to understand the gravity of what they're doing and to problem solve, and they can easily make mistakes. And of course, disconnection, no more than 2 hours, preferably only 20 minutes for their shower. But of course, for contact sport, up to 2-hour disconnection is allowed. So let's have a look at some of the infusion or giving sets. We tend to focus more on a 90-degree Teflon cannula, 6 millimeter in length. There are some issues with kinking, which I'll describe a little bit later, but generally speaking, the insertion mechanism is built in, and that's quite attractive for use for patients. But of course, if that's not working for the patient, we can also use a steel-tipped cannula, which is also only 6 millimeter or 5 millimeters long, And but the disadvantage of that is that there is an anchor point, a separate anchor point for disconnection and connection, and patients don't like that extra tape on their body. You can, of course, get insertion sets that allow for an angled insertion at 25 to 45 degree angle. They're longer in length and quite painful, and we don't use them, but we do use them for neonates because we want to get the needle just gently under the skin rather than at a 90 degree angle on a 6mm needle. All right, so what can go wrong? I'll show you what generally goes wrong with set insertions. So ideally we want, when we open our set, our needle is sticking above the cannula. That's very important. But as the patient starts to remove the tape, if they're rough with the mechanism, what happens is they pull the mechanism upward, and the plastic cannula tends to slide up above the sharp needle, which means that when they insert this into their body, plastic hits first, it buckles and bends and kinks the cannula. And that's a failed set. They only figure that out around 4 hours later as hyperglycemia starts to take place. And it's all about just attention to detail and being careful. Of course, cannulas can also dislodge due to physical activity, etc. And the other thing is just bubbles in the reservoir. And again, that's just around attention to detail when filling the reservoir with insulin. So common issues are dislodgement and kinking of cannulas, sets not adhering well, so sweating, during sports, the tapes come off, skin irritation and allergy to tapes. I'll be talking again in a different talk to that. Air bubbles in the lines, pain and discomfort, might just go in on a spot where it's rubbing against muscle. When in doubt, we say to patients, please change your set, just start again. So in summary, very important to reinforce adult supervision. We remind patients over and over what their total daily dose of insulin is for disconnection purposes, sick day management at every opportunity, and ketone management. If ketones develop, we discourage the use of the pump to correct. They must do a full set change and use an insulin pen to correct their blood glucose level at that point. That way they 100% get insulin and turn the ketones down, and then they can continue to use their pump safely, assuming the pump is still operating well. And good skincare, and again, I'm going to be talking to that later in the day. Thank you very much for your attention. I've included a couple of websites there for you to look at. The pump companies do offer a lot of good information, and also my email address.